This video demonstrates the stepwise management of small pupil of varying severity while performing phacoemulsification. Our first case is a 43-year-old female with immature senile cataract. It is a fairly good dilated pupil to start with. We construct our main ports and our side ports. Once we finish the rexus, we do a regular hydrodissection. As the phacoemulsification proceeds, the surgeon starts to see the flutter in the iris, suggestive of an early IFIS syndrome. The surgeon continues to perform the phacoemulsification, and being troubled by the air bubble inside the AC, the surgeon then decides to withdraw the probe and replace the air bubble with the viscoelastic. But soon realizes that the pupil has come down considerably. One of the most important tips for young ophthalmologists here is not to panic in the situation, and if not medically contraindicated, can inject intracameral adrenaline. In some cases, you may get 5.5 mm pupil, which makes phacoemulsification easy in these cases by making sure that the phacoemulsification tip stays in the central 3 mm pupil. One can also use highly cohesive viscoelastic to dilate the pupil and complete the phacoemulsification process. Thus, in some mild cases, if not medically contraindicated, intracameral adrenaline and visco-assisted pupillary dilatation should be utilized. The second case scenario deals with a rigid mid-dilated pupil in a case of the brown cataract, hypertensive male, and non-availability of pupil expansion devices. It is important to stain the capsule so that the rexus margin can be easily made out under the iris. In such cases, we prefer to make limbal incision, which will make conversion, if necessary, easy for the young surgeon. We can see that the staining of the capsule is actually helping the surgeon to make the rexus in a much better and controlled way. It is important that the phaco tip remains in the central 3 mm zone, which is actually a safe zone, which ensures that you don't touch the pupillary margin or damage iris. With the accurate chopping technique, you can chop the nucleus into small pieces. You can use the second instrument and the vacuum of the phacoemulsification to bring the pieces in the central 3 mm zone and then emulsify them in the center. Make sure you protect the endothelium with a high quality viscoelastic material. Bimanual irrigation aspiration ensures safe cortex aspiration. One also needs to be sure that there is no residual cortex left behind, and if any, should be easily dealt with. Our third patient is a patient who wants a topical surgery and a multifocal IOL, but the pupil is very rigid. We decided to go with topical surgery despite a rigid pupil and with the use of intracameral lignocaine. The Staining of the capsule certainly helps, as discussed in the previous case also. It is important for a surgeon to decide the stage at which he would like to use any pupil expansion devices. In this case, after having emulsified a small piece, the surgeon decides it will be better safe if we use the iris hooks in this case. 4 equidistant stab wounds are then made to allow insertion of iris hooks. The iris hooks are then gently inserted. Also, one has to ascertain not to damage the rhexis margin and not to engage the rhexis margin along with iris. One has also to keep in mind that the patient is under topical anesthesia and the things have to be done in a precise and quick way. Once the iris hooks are in place, the phacoemulsification then can proceed in a regular way. After the IOL insertion, it is mandatory to remove the iris hooks in a precise and atraumatic way by turning the curved end parallel to the wound before taking them out. Our last case is of a dense uveitic cataract with 1 mm pupil and a dense pupillary membrane. One has to be patient enough to do meticulous yet atraumatic removal of the pupillary membrane and the adhesions underneath. Once the pupillary membrane is removed, one can plan to put pupillary expansion devices. In this case, we used iris hooks as a preferred mode as the extent of posterior synechiae were not known. One can inject viscoelastic underneath the pupillary margin to create a space for iris hooks to enter. Once the first iris hook is in position, the second iris hook is inserted in the same plane, then rotated to the desired location. With iris hooks in place, now we have adequate pupillary dilatation for us to proceed with the further phacoemulsification. Iris hooks are then removed in a similar atraumatic way. So apart from pharmacological and mechanical devices to manage small pupil, what a young phacosurgeon needs is definitely a confidence to do it. Thanks a lot for watching the video.